session where we speak about how to deal with sudden intraoperative challenges of different types that we may sometimes face. And each of the speakers are very, very senior, and they would hope to touch on one particular topic and enlighten you a little bit more about it. So we start with and I'm just hosting this for one of my best friends, Dr. Sudeep, who can't be here today. But I managed to trace his talk. Could you please connect this?
Yeah.
Where he is going to share his insights about how, when you have planned a premium IOL surgery and you've got some intraoperative mishap, like a PCR, how are you going to manage to still continue and get away with it?
HDMI लगाना. Yeah, actually he's got it loaded over here. Oh, sorry.
So how do I play? Just play?
You go on with my talk.
Make it louder, please. Volume. Loud karo. This is the video itself playing. That's fine. Just loud kar dijiye, please.
Audio है?
Audio must be there.
Yeah, it's there, but it's not coming.
So this is something that one definitely doesn't want to have, but it's very important, and this is something that you have to practice in all your surgeries, because PCR is something that all of us have. If somebody says that he doesn't have a PCR ever, we have to doubt whether he does any surgery at all. So one thing that you do is you do not shut the irrigation. So if you are in position 3, come to position 1. If you are in position 2, again come to position 1. Whichever position state you are in, whether it's during IA or phaco, it's important that you do not go to position 0 and shut off the irrigation, because the anterior chamber collapses and the vitreous moves forward, the PCR becomes larger, and you have vitreous prolapse. Then with the irrigation still on, so your handpiece is still inside, you take whatever OVD you have. If you have one of the high-end OVDs, fine, otherwise just use HPMC. Go through the side port with your other hand and inject enough viscoelastic to stabilize the anterior chamber. As you're injecting, you shut off the irrigation and you come out of the main wound. So if you have this, fine, but don't wait for it. Just use anything that you have on your table. And what you do after that depends on what stage the PCR happens, early in surgery or later on. And if there's a large amount of nucleus left, you cannot really do anything other than convert to an SICS or ECC, whichever one you're competent with. If it's a small amount of nucleus left, you can actually do a phaco with a dispersive OVD in place. Sometimes you inject continuously and do the phaco. And if there's a small bit of vitreous, with vitreous in the anterior chamber, then you have to do vitrectomy. Do not continue with phaco, because that will produce a lot of traction on the retina. And if there's only cortex left, do the vitrectomy if needed, and then IA. And depends on what sort of a capsule you have left, you can implant the IOL, or sometimes you can even implant IOL earlier before your IA. So this was a brown cataract, and it was for a toric IOL. And sometimes, so I don't do marking like this anymore. I do it on a slit lamp. But when you do a brown or a black cataract like this, the problem is you relax when you're doing your IA. And most IA PCRs happen during IA. So there, I have a PCR, and I was holding the capsule actually with the IA, so I release that with the other hand. Then inject viscoelastic, come out. This is a more dispersive viscoelastic. And I decide to inject. Actually, there was not even much of cortex left at that stage. So it's not always that you can convert the PCR into a rhexis. If there's a small flap, you can do it. Otherwise, it doesn't work. But then most of the time it's stable, and I could actually implant it in the axis because it was a small central tear. The other thing that you do not do is, we always keep teaching our fellows that, or students that, do not polish the posterior capsule in PPC, but then we don't follow it always. You know, so okay, it's so tiny, nothing's really going to happen. So I actually finished everything. Even my IA is over. And just for that little bit of posterior capsule opacification, decided to touch it, and there the PC is, there's a hole in the PC. but I had the sense not to shut off my irrigation, inject viscoelastic, and then this was a small flap-like tear, so I could convert it into a rhexis, a posterior primary posterior capsule rhexis. And believe me, it's a lot easier to do a rhexis on the posterior capsule than it is on the anterior capsule. There are no zonules to pull the capsule, the rhexis out, so it's a lot easier. And then you can implant the IOL of your choice. There's absolutely no problem. This is a Technis 1 multifocal IOL, and it's absolutely stable. It goes between the anterior rhexis and the posterior rhexis. It's very stable. This was a Morgagnon cataract. And as you can see, the over-enthusiastic marking on the cornea. So Morgagnon cataracts, the thing is, it's a small nucleus. The capsule is very, very mobile. So it really comes forward, and I've caught the capsule. So again, I had Viscoat in hand, no financial interest in that. I inject Viscoat behind the nucleus. Then it was sort of, the nucleus wasn't positioned. You don't want to really manipulate it too much at that point. So I just move it into a place where I can emulsify it easily. And once it's done, I can implant the IOL into the bag. So the important lesson is that you do not remove or stop your irrigation, pull out your handpiece all of a sudden, and then you really can't implant the premium IOLs because they won't go into the bag anymore. This was one of my earlier cases. It's a very intumescent cataract, really huge patient, bull neck, must have weighed about 120, 130 kilos. So there was a lot of pressure during surgery. And here if you see, like I said, it's one of my earlier cases, so you saw that I hadn't injected viscoelastic when I came out. This is not something that I would do at all. And because of that, the vitreous did come to the front. It was a very soft cataract. There was almost no nucleus. So I could actually just aspirate out the rest of the nucleus, do a vitrectomy, and after doing a proper vitrectomy, you can actually do your eye. There's absolutely no problem. And then implant the lens. There was sufficient capsule. There was a large capsule, if you see on your screen on the left side. And this was actually a T9, so the highest astigmatic correction. So I couldn't actually place it absolutely in axis. That probably would have made it a little unstable, the haptics. But then it was about 10 degrees off. But then in a T9, he was still happy because it's such a large astigmatism that had to be corrected. And this was a very large PPC. So when you see something like this, such a large PPC, you can actually expect the PC to go at some point of time. So I'm removing the epinucleus now, and that's when the PC opens up. So as you see, I'm even holding on to the epinucleus on my phaco tip. So I'm still in position 2, not in position 3, because if I leave it, it's going to go into the vitreous. So once I inject viscoelastic, then I visco express it out, do a vitrectomy, do a proper vitrectomy. You have to practice all these vitrectomy and all in all your routine cases. There's nothing like a venous vitrectomy or a sponge vitrectomy nowadays. You have to have an automated vitrector. Even if you're doing an SICS, you cannot really do a sponge or a vectis vitrectomy. And once you do that, as you can see, the one indication that you can of course use triamcinolone, but the one indication that your vitreous is fully out is that your cortex comes out very, very easily after that. And once that happens, I can implant. It's a 3-piece intraocular lens. I can't implant a single-piece lens because this is going to go into the sulcus, not into the bag. But you get a Technis 3-piece multifocal lens. So we had planned for that, knowing that the PC will probably rupture. And then the important thing is you do a optic capture in the rhexis so that the power doesn't change. So you just tilt one pole under the haptic, under the rhexis, and then the other one also, and that's very stable. Thank you. I'll go on with.
All right. Is there anyone who has any questions? If not, then I have one. Just anybody else? Any questions? So here's my question to the panel. Now, when you've got a patient with a polar cataract, and it's a fairly, the polar cataract that's kind of talking to you and saying, hey, I'm going to open up. What do you do when a patient asks for a multifocal lens here? Aru? Get the next ready. We'll start exactly in 4 minutes. You can speak just like that.
Because he's recording all the sessions, so the camera.
Then please come and have a seat here and speak.
It's working now. It's working now. When you dropped it, it worked.
See, most of these patients with posterior polar cataract, they present to us quite early. They're very active, and multifocality is a very important aspect of their pseudophakic post-pseudophakic rehabilitation. So I think I have done multifocal for these patients also, but I tell them that if I have a intraoperative posterior capsular rent and I have opened up, the vitrectomy has been done, I may go for a traditional lens. So appropriate counseling is absolutely important.
Okay.
They should know that there will be a situation where they have to adjust to pseudophakic presbyopia.
Perfect. Is there any other point you'd like to add?
Yeah, it depends a lot on whether it's the first eye or the second eye. So if it's the second eye and if it's the second eye, you've done a multifocal already in one eye and got away with it, the chances are that you'll get away with it in the next eye also.
But that's also a bigger challenge, right?
I know, I'm coming to that. So the counseling begins in the first eye itself. That yes, if you're willing for multifocal, we'll go ahead, understand the risks. If we can do a multifocal in the first eye, we take the same chances and go ahead for the second eye. Depending upon how the situation unfolds in the second eye, we might have to take a call and change course. You may have a multifocal in one eye and a monofocal in the other eye. That's good. That's pretty good. We do that now routinely. Indications for multifocal have been changing. And oftentimes, if the patient has a monofocal in one eye and understands the pros and cons, we do do a multifocal in the other eye. So that's
my question.
I had assumed that it is the first eye that you're operating upon, because when you're doing the second eye, the considerations are different. So my assumption was it is the first eye, patient doesn't know what is happening. Then I tell them that I will keep him moving.
I think anyway, even if it's the second eye, we have to tell them that there is a possibility that we may not be able to put in a multifocal in one eye and it may go in the other. I have a question, Dr. Minu.
One thing is, I show them their cataract in the video monitor, and then show the types of cataracts on my screen, and then tell them that this is what is peculiar about you, because that is what will make them understand that there is a peculiar type of cataract in their eye. Then they will understand it much better, and they will take it otherwise they'll think sometimes that you have created a problem and then not implanted as lens and all those. So visually, if I make it clear, it is better.
I make it a point to note it on the file also. The risks of posterior polar cataract explained, counseled and explained.
So, are the 3-piece multifocal IOLs still available? We used to call for them from Chennai. So, is that not an option that you undercorrect for, because it's going to be slightly myopic if it's going to be in the sulcus? It's going to be the same power if it's going to be in the sulcus with a posterior optic capture. Is it a good idea to even consider keeping a 3-piece multifocal standby, especially in the second eye and even if in the first?
I always have a full set of inventory in my OR.
Yeah, we don't get them in Bombay. We go to order them from Chennai.
Sensor is available.
Is that right? Okay.
Three-piece multifocal, I have used it maybe 4 or 5 years back. After that, I never.
Yeah, it's not very easily available as far as I know.
Oh, you're talking about multifocal 3-piece?
I'm talking about a 3-piece multifocal.
Oh, yeah,
I think it's a great idea. I know Alcon makes them. I know they're available in Chennai. We should find out where are our local distributors that can organize those. Should there be someone who's picky and wanting a multifocal IOL? I still think that could be a consideration. All right? We move to the next. I'll talk on intraoperatives on later. Yeah. Can we have the lights off?
After you,
Is the doctor?
in the order it's Dr.
You want to speak third? Yes, third. So I'm going to show you a video now where I discuss threadbare my experiences with an intraoperative zonular dialysis and the management strategies. Here are a few cases of intraoperative zonular dialysis and the way in which they were managed. Now, managing a preoperative zonular dialysis is a planned event where the surgeon actually evaluates what is the extent of the zonular dialysis with a slit lamp, often aided by an ultrasound biomicroscopy. A strategy is put in place, and both the surgeon and patient are aware of what is the condition of the eye and what the possible outcomes are. As opposed to this, an intraoperative zonular dialysis is an unplanned event. It catches the surgeon by surprise. He almost always cannot tell what is the exact extent of the zonular dialysis. A new strategy now needs to be put into place, and thus all of this can result in a suboptimal end result. Now, this patient with a pseudoexfoliation, phacotonesis, and no obvious subluxation is a good candidate for a CTR. After achieving a pupillary mydriasis with a Malaysian ring and a rhexis, the surgeon now introduces a suitably sized CTR with a hand-on-hand maneuver through the main incision. The trailing eyelet is hooked on by a Sinskey hook and then rotated and introduced into the subcapsular space, after which it is released, giving good equatorial stability to the capsular bag. In this case, while attempting to remove the last fragment, the surgeon notices a downward flapping of the superior capsular bag, signifying a zonular instability. The surgeon attempts to put some viscoelastic, which results unfortunately in worsening of the zonular dialysis and a vitreous disturbance. The surgeon then introduces the CTR with a hand-on-hand maneuver, resulting in a progressive opening out of the capsular bag as demonstrated, after which the trailing eyelet is introduced into the subcapsular space and disengaged with the help of a spatula through the sideport incision. Towards the end, the surgeon notices a peaking of the pupil, which signifies disturbed vitreous. Now, this is managed with a manual vitrectomy with the Varner scissors, and as you can see, the end result is a stable capsular bag and a nice round pupil. Whilst attempting epinucleus removal in this case, the surgeon notices linear folds in the underlying posterior capsule, for which he performs a viscofluid exchange. The surgeon then introduces the capsule tension ring in a hand-on-hand maneuver, and this technique of introduction of a CTR is a linear circumferential delivery of the CTR. The trailing eyelet is then hooked on with the Sinskey hook. It is introduced into the subcapsular space, and the point of release of the hook is such that the CTR's open ends come to lie at a place opposite the area of subluxation. In this case, the surgeon accidentally yanks the inferior capsular bag while attempting irrigation aspiration, resulting in a large zonular dialysis, for which he performs a fluid visco exchange and then introduces the CTR. Please note the CTR is always introduced from a point opposite towards the area of the zonular dialysis with a view of preventing it from getting worse, followed by its eventual disengagement and resulting in a nice stable capsular bag. At the end of a seemingly uneventful phacoemulsification, surgeon introduces the IOL, but accidentally pushes down on it, resulting in a large zonular dialysis. Now, this is merely managed by the rotation of the IOL to bring it to lie in such a position that the haptic comes and lies against the area of the weak zonules. In this case of seemingly uneventful phacoemulsification, at the end of nuclear emulsification, the removal of the instruments reveals the presence of a significantly large zonular dialysis. The surgeon insufflates the bag before introduction of the CTR. Please note the plane and the angle of entry of the CTR. It always needs to have a flattish angle of approach. Something too shallow would result in the angle. Something too deep would actually result in the capsular bag coming out upon itself. In this case, after a successful second chop, failure to disengage the probe from the fragment results in a significant zonular dialysis. The CTR in this case is introduced with the Fishtail Technique, which is a simple, safe, effective, and zonule-friendly technique of introduction of the CTR, which now negates the need of a circumferential delivery of a CTR, which has its own inherent issues. Now, here's how it's done. The capsule tension ring is flexed and held flexed with the help of a forceps. The apex is introduced through an unenlarged main incision and then comes to lie under the opposing capsular rhexis edge. Then, turn by turn, one eyelet is introduced and released into the corresponding subcapsular space, resulting in a nice, stable capsular bag. The use of an injector for inserting the CTR allows for ease of insertion because it is directly inserted into the subcapsular plane. In this case of grade 3 nuclear sclerosis, after a successful second chop, the surgeon finds a difficulty, in fact, an inability in actually rotating the nucleus. Now, this is because of a zonular dialysis. The surgeon first performs a visco-BSS exchange and then attempts to put a CTR in the capsular bag with a hand-on-hand maneuver. However, halfway through its insertion, surgeon finds an actual difficulty in putting in the lens. In fact, the zonular dialysis has got worse and the nucleus is tilted. So surgeon now offers stability to the capsular bag with the help of capsular hook that actually pulls the bag up, after which he very easily and comfortably is able to introduce the CTR into the capsular bag. Having achieved that, the surgeon now very carefully and comfortably completes the nuclear emulsification, the introduction of the IOL in the capsular bag, the removal of the capsular hook, and an optimal end result. So what has been my learning through this? In patients with an intraoperative zonular dialysis, as you can see here, the mere introduction of capsular hooks to stabilize the bag may not be adequate because you can't really tell how extensive the zonular dialysis was. So in this case, the surgeon has actually introduced only capsular hooks to stabilize the bag. And despite a very careful emulsification up to the very end, because of lack of equatorial stability, the entire capsular bag was emulsified, and then there was a significant problem to deal with. So, what my learning really is that when you have an intraoperative zonular dialysis, yes, you go ahead and put capsular hooks to stabilize the bag, but in addition to that, introduce a CTR as well to give you that equatorial stability of the capsular bag and a stretch to the capsular bag. So at the end of nuclear emulsification, you have a bag that's absolutely stable and bang on in place. Now, this patient with a soft cataract had a zonular dialysis during nuclear emulsification, for which the surgeon introduces a capsule tension ring as demonstrated. However, after its introduction, if any part of the capsule tension ring is still visible, it signifies a decentered bag which now requires additional support. In this case, the additional support was achieved by the scleral fixation of a capsule tension segment. A capsule tension segment can also be introduced in a phakic eye with the view of stabilizing a subluxated capsular bag. The CTS can be introduced through the main incision, slid under the rexus, placed at its proposed point of fixation, after which a capsular hook, as you can see, hooks onto the central eyelid and is pulled outwards and stabilized thereafter. Now, what you achieve with this is a very high level of stability of the capsular bag, which allows for ease of subsequent nuclear emulsification. At the end of nuclear emulsification, one of the straight needles connected to a tenoproline suture is passed through the central eyelid of the capsule tension segment, and this is kept ready outside the eye. The capsule tension segment is now introduced into the eye through the main incision, and it is introduced into the capsular bag and comes to lie at a place at the proposed site of scleral fixation. One of the two needles connected to a tenoproline suture is now introduced into the eye at a point opposite the area of the proposed fixation, and it is railroaded and exteriorized with the help of a 26 number needle to come to lie in a shelved groove made 1.8 millimeters behind the limbus. The two needles are cut and the suture ends are pulled out and tightened, and the extent of tightening such that it causes a well-centered bag. Can we have the lights, please? Here are a few cases of intraoperative zonular dialysis and the way in which... Thank you. We can get to the next slide. Please, ready. Right. Any questions? This is just to compile a few cases that I worked with. No? Right. So, Suvin, would you introduce the next speaker? Are there any questions in the audience? Or then, yes.
Showed the second technique of inserting inserting the CTR ring, no? So can it be used for superior dialysis also? Like you made a loop and then inserted it.
So fishtail is not as easy as it looks. I'm sure everyone here will agree. It does work, but the challenge in that is holding it in its flexed position and maintaining that flexed position while it enters into the eye. So I don't use it for superior subluxations. Once in a while, if I've got a significant inferior subluxation, or if there's a subluxation which is inferior, which is like 3 or 4 clock hours, and I'm a bit concerned that when I put it in a hand-on-hand maneuver, I might make the Zollner dialysis work. It is in a case like that where I would consider putting in a CTR with the fishtail. Otherwise, with a hand-on-hand maneuver, almost always it works well. Sometimes when you're putting in a CTR with a hand-on-hand maneuver, you're looking at a rigid PMMA device. We are looking at a device that is about 11 millimeters in its diameter. We are aiming at introducing it through a rhexis that is 5.5 at an angle that goes between the inner lip of the wound, then through the rhexis, then into the bag, and you're rotating it around. It's a question I've often asked. Should you go this way or should you go that way? I think either way it could actually be a little bit of a compromise, and there's no telling that you're never going to necessarily have an absolutely brilliant result. Just one take-home message I'd like to give you is that I always, now what I do after I made this is that I add a little bit of a cohesive viscoelastic to create a space between the rhexis edge and the nucleus to allow for ease of insertion of the initial, the leading eyelid of the CTR. वो अंदर चला गया ना, and then if you don't let it slip back, it's going to go into the bag. So that's the other challenge. If you can't see and you end up with one in the sulcus, then it's hell to try and bring it out and sort it out. And moreover, you then no longer have a CTR in the capsular bag, and you don't have a stable bag to carry on with your procedure. And finally, I think I would, once I see a Zollner dialysis intraoperatively, I will always put in a CTR then and there and not at the end or not at any other time, because once I've created a Zollner dialysis, for me to be able to safely complete the phacoemulsification uneventfully, I would want to achieve and I would aim to achieve a stable capsular bag for the rest of the surgery, which only a CTR is going to give me.
I think Dr. Suvira very well presented. Most of the important points have brought out.
Yeah.
I just wanted to bring another specific issue to the
Students.
Focus of the audience.
Yes.
Is sometimes these eyelids, they don't have uniform diameter, and when you are dialing in the end of the CTR, it gets stuck. The Sinskey hook, and there is a mismatch in the size. It gets stuck. So you need to have another second device. Another Sinskey hook to disengage it. So sometimes it has happened, you're stuck inside, it doesn't come out. So you should have always the second Sinskey hook available.
So I tend to introduce a CTR through the main incision, and the trailing eyelid I introduce with a McPherson's with its convexity to the left, like how we used to put in the rigid 5mm, 6mm lenses. With that, I maintain a very good hold, or kuch bhi ho jaye, it doesn't leave, it just goes.
Yeah. There are so many ways of implanting it, but this is one of the problems that I have encountered.
Couple of comments about the fishtail technique. Now, one is the incision size was a little larger than usual. Second is should be very mindful of the type of CTR that you're using and the manufacturer. There are different types of PMA. If you use the Madhu Instruments one, it's a very flexible CTR. You may probably be able to do a fishtail. If you're using an Appa or Orolab, you're going to break it. So be very careful. If you're not very confident with the fishtail one, I'd rather go the conventional.
See, I always hold the trailing eyelid with a micro rhexis forceps.
Great.
It goes in through a 1.5 incision, and you can place it directly at the rhexis margin and then leave. It goes in completely.
The control on holding it is a lot more with a forceps than with a Sinskey.
One small comment about the microrhexis forceps or any microforceps that you use. I've had this nasty experience and presented as a challenging case once. Is that if you're using, preferably use titanium ones. If you're using slightly oldish one, steel ones, the sleeve, if it's split, you see it can lead the jaws to lock, and don't leave the eyelet till the end, and when you're secure that you're going to leave it and it's going to go on its own and not going to come back at the end of the jaws. You see, the jaws are open like this, the sleeve is over here, okay? Now, you let it go, and by the spring action, it comes and recoils, it gets stuck in the jaw. Now, you can't release it. You can't, do anything, you're stuck. I was stuck with a CTR like that, and then I had to break that eyelet and then let that CTR go because I was, no way, I couldn't go in, leave it, I couldn't come out. So be very careful. It happens with the steel ones. Use a titanium one, doesn't cost a big deal these days.
Thank you. Thank you, Dr. Subin. Thank you all, actually. I now invite Dr. Boral Subhendra Kumar to present his paper on expulsive hemorrhage and a suprachoroidal effusion during phacoemulsification.
Thank you, Dr. Suvira Jain, Dr. Sudeep Das, for inviting me in your course. It is my great privilege to talk on in such a hall of full of great phacosurgeons. So this is suprachoroidal effusion, and the more deadlier form it is suprachoroidal hematomas are not. It is not very common, not very uncommon. Also, it still occurs in everybody's hands. Nobody is going to escape from this kind of complications. Like I'll showcase one case. This is by courtesy Dr. Shubhen Bhattacharya, that he was operating on a on a case of subluxated lens, and suddenly the lens has to be expelled. But suddenly you can see the intraoperative black glow. That means, and he fortunately he just closed the wound and came out. So this kind of situation you may face. In your practice, so supracardon hemorrhage, actually it is a very rare condition. Actually, it's a suprachoroidal space, the potential space, which which contains a 10 microliter of fluid normally in between it is virtual space. So it between the sclera and the choroid. So there is collection of blood in this space called suprachoroidal hematoma. There are some, some predisposing factors, like if the patient is aged and is high myope, and there are a lot of, like you can see the arteriosclerosis, patient is diabetic, the vessels are quite fragile. If there is some collection of blood into the suprachoroidal space, it gradually increases because of the friability of all the blood vessels, capillaries going through the suprachoroidal space. So this kind of situation, arteriosclerosis and diabetes, they increases the aggravation of this kind of situation. So because of like vitreous loss and due to the cataract surgery or anything else, that can also the post-traumatic also increases the chance of suprachoroidal hematoma. So usually not on all cases it is indicated to go for the surgical drainage, and if the patient there is extreme high IOP and persistent flat anterior chamber kissing choroidals, retina is at the wound, that is incarceration, and patient is complaining of like extreme pain, and the surgeon couldn't deposit the intraocular content, retina is at the wound. So in those situations you have to drain the suprachoroidal blood, but it is not a job for the, like frankly telling you, it is not a job for the cataract surgeon, it is anti-segment surgeon. You have to refer to your VR colleague as on required. So intraoperatively it is your duty just after removal of the cataract. So bulging for the diaphragm, lens iris diaphragm, vitreous starts coming out, iris prolapse, everything, prolapse of the or retina at the wound. So in those situations, they are the signs of the intraoperative expulsive hemorrhage, suddenly absence of your glow. So primary management depends on it requires a tight closure of the incision. Even with the needle, you can see if it does anything is which is available at that moment. So posterior anterior radial sclerotomy, it is required as an emergency basis, and it should be done by the anti-segment surgeon intraoperatively. So postoperatively drain you can be done at any time till 2 weeks, and because ideal time of drainage is 7 to 14 days after the primary surgery for adequate, because the clot has been lysed properly, so adequate drainage is possible. So secondary management, you have to refer your patient to the VR colleague. So surgical management, it described earlier, is a radial sclerotomy, actually 2 to 3 millimeter sclerotomy, which is required at any one quadrant, infratemporal, infranasal quadrant, and you can introduce the cyclodialysis spatula with into the suprachoroidal space gently to facilitate the flow of the blood. Rositi et al., they described one technique of placing anterior 23 gauge cannula anteriorly and 2 to 3 millimeter behind the limbus, and they just introducing the cannula, one cannula single drainage, where the maximum height of the suprachoroidal blood is there. But we invented our situation technique. That is, after doing vitrectomy, we are injecting the PFCL and introducing our cannula, 23 gauge or 25 gauge cannula into the obliquely into the supracordal space, 10 to 12 millimeters away from the limbus, and this is called modified posterior drainage of blood. We have published this our technique into the IGO. So this is a situation where there was retained lens matter and video is not running. Okay, it's not coming in the slide. Yes, it's not coming in the screen. I'm playing from my laptop.
No, you just exit your presentation.
Yes.
Open from here.
No. Three, four videos.
Leave them one by one in your files otherwise.
No, basically this is not coming in the screen. Can you see?
Why is it's come? Everything's come. It's come. Is it playing now?
Not playing.
So can we go back to where you saved the videos? Forget the PowerPoint.
So that I can.
Yes, we can see them. Connect this, please. No, it's not. Hold on. Pause. It's not connected. करिए. कर सकते? कौन कर सकते हैं? We need to connect the screen. Can we show the screen again? The need
Then just take it out, plug it in again. That's right.
Logistic.
Keep that screen on.
There is huge choroidals here and lot of vitreous hemorrhage, so I'm clearing the vitreous hemorrhage and then introducing the trocar cannular blade obliquely, posteriorly 10 to 12 millimeters away from the limbus, and you can see I'm injecting PFCL from inside, and then there is egress of blood through the 23 gauge trocar cannula, and slowly you can remove the PFCL, and at end of surgery you can inject the silicone oil, especially if it is patient the eye is hypotenuse, you can go for the 5000 silicone oil, and postoperatively you can see preoperative picture, hyphema, there is iris incarceration at the wound, kissing choroidals, you can postoperatively you can see the great picture, everything is absolutely flat and everything is on. Now in this case I started the case with the AC maintainer, so I put the infusion into the anterior chamber and thus injected the introduced trocar cannular blood. You can see the dark colored that supracordal blood is coming out. It is altered blood. You can see dark multiple trocar cannula you can insert 10 to 12 millimeters away from the limbus, and slowly you can just sorry no, I have to showcase the result also because it is there embedded into the video. So 3-4 cannulas you can also put multiple cannula drainage. You can introduce the cannula, trocar cannula at that area of maximum elevation of the choroidal, and you can inject PFCL, and external passive drainage of blood is possible through the multiple posteriorly placed cannulas. So it is not mandatory to drain all the blood, so remove the PFCL and inject the silicone oil. You can jolly well see up during silicone removal the retina is absolutely flat, and here I have planned for the gluteal surgery also after doing this removal of the silicone oil, and you can see retina is absolutely okay, and there is, you can see the choroidals also totally gone. Postoperatively you will see great pictures like this. Retina is, see patient we gained 6/12 vision after the surgery, after removal of the silicone oil and implantation of the gluteal. So this is another case where the retinal detachment along with expulsive hemorrhage, it was there. It was giving picture of kissing choroidals, and after checking all the trocar cannula, it is inside the vitreous cavity, done the vitreous vitrectomy, and actually it was falsely looking the expulsive was kissing choroidals because of presence of retinal detachment. It's not always possible to check for the how much elevation is there. So I have identified the break, and I have seen the disc is there. So after completion of vitreous hemorrhage, inject the PFCL bubble to drain the subretinal fluid through the anteriorly placed breaks, and finally all the after drainage of subretinal fluid, you can actually assess the how much elevation is there. So how much it is, suprachoroidal elevation was not that much after after settlement of retina via anterior drainage of the subretinal fluid. You can start doing fluid exchange, and finally do the vitreous base section, fluid exchange, followed by removal of the PFCL, and finally injecting silicone oil at the end of surgery. And this is rest of the procedure. So here also you can do the drainage, because the elevation is not that much. So 1 or 2 cannula drainage is good enough, posterior drainage. So you can see the amount of blood is not that much, it's little bit lies blood, and settle the retina, do laser and inject silicone oil in the end of your surgery. Postoperatively you see this kind of picture. Still there is some kind of blood, patient is still doing follow-up, vision is not that much under oil. So this is good prognosis cases, means one quadrant hemorrhage and supracardon hemorrhage, you will get good result. But hemorrhagic kissing choroidals with total retinal detachment and retinal incarceration, these cases are not good enough. It is very difficult to remove the silicone oil, and patient is suffering from the persistent hypertony. Thank you.
So may I ask a quick question?
Yes.
For us anterior segment surgeons, this must be really easy for you. But so one is that when we see the suprachoroidal hemorrhage occurring, let's say I'm a surgeon operating at 12 o'clock, I'm going ahead with my phaco,
Yes.
and suddenly I see at 7 o'clock there's the dark reflex that's starting to form.
What are the precautions?
Ji?
What are the precautions you should take?
No. I want to know actually about this. Like if I get this tomorrow, I want everyone here to be able to go home and manage it in your technique, because it looks very doable, but it's a world of the unknown for us. So I'm sitting at 12, superior surgeon, there's a choroidal hemorrhage, suddenly you can see there's a dark mound happening, difficulty in various maneuvers, and at what point do you decide that yes, I'm going to now tackle this? Is your first choice of surgery putting in the trocar cannula? If so, no. So
your first duty is to just close your wound properly.
So do you do a visco-fluid exchange if you're doing phaco and come out?
Yes. Raise the intraocular pressure, wait for some time, try to give the suture at your phaco wound.
Yes.
Don't do any kind of maneuver, wait for some times, and try to see whether, see the fundus or see the amount of the dark glow, whether it is aggravating or not, whether the iris is prolapsing or not, and try to inject start the patient on mannitol, Diamox, wait for some time, maybe 1 or 2 hours, then you can again review the patient and do the complete your surgery. Or it is better to postpone the surgery, do it in the next day or after 7 days. There is no hurry. You are all whatever maneuver you are doing, it is good for the patient. So patient will understand it. They will not have misfaith on you.
So what would be your ideal time for your second surgery to deal with it?
If the expulsive is not aggravated, that is one quadrant hemorrhage or a very mild elevation, you can see the most of the retina you can see, or your VR colleague friend can see. But if it is there giving some kind of green signal after 7 days without drainage, you can complete your phaco. IOP has controlled. But if it is not aggravated, it is aggravated, then wait for 7 to 12 days, 7 to 14 days time for the adequate clot lysis for the better drainage.
And what would you treat the patient with at that point? Is there anything different?
Anti-glaucoma, nothing.
Tablet? No. I mean
not systemic steroid. Because in most of the patient are diabetic and hypertensive.
Please stand here, we want to hear this. So yeah.
Most of the situation, patients is diabetic and hypertension don't use
Yeah.
systemic steroid also.
Please
Sorry.
sit.
Don't use systemic steroid also. That will aggravate your, that will complicate the systemic conditions also. So these are the things you should remember.
And when you drain it, what is the gauge of the trocar cannula that you're using?
Either 23 gauge or 25 gauge. Even 27 gauge, it is, I have not
Which
tried,
you
but
pref- Which would you suggest for us as people not experienced?
23 gauge is not easily available right now. So 25 gauge is easy
I
to.
have a small comment. I think
Non-valve cannula. 23 gauge, non-valve cannula. 25 gauge, sorry.
I think, Suvira, we missed a very important point which Dr. Shubhendu said, that just close and refer to the VR surgeon. We do not expect, they do not expect us to meddle with
No,
this.
sure,
Just a
fair
minute. And sclerotomies, primary, is very debatable now. Because whether you, Shubhendu, would you agree with me? Primary
Yes.
sclerotomy
It's
because
not at all required.
not at all recommended
Because
because
it
you
is
are
not your
allowing more
decision.
and more blood to come in
Yes.
over there and worsen.
What happens for an anterior segment surgeon, they are promised for many things. This is the premium IOL, this is absolutely suitable
Correct.
for your eyes, go for this one, go for that one. But some disasters happen during the surgery. So how you can save your face? If you are just stopping your surgery and explain the patient, it is not possible, so I will do it after 7 days, they will not have any grudges against you. So they will agree, they will accept all the facts. But that is the situation where some kind of panicky like situation, patient is what kind of expectation, what should I answer, how can I save my face, all this kind of situation may come in the private practice. That is the main problem.
The closing, don't look at the beauty of the sutures.
Yes.
And don't go for 10-0 and all those.
Yes.
I have seen in front of me 10-0, one I put, the second I put, that one break off. So don't look at beauty, don't look at iris coming inside. Get whatever you get, keep it closed with your thumb or your forefinger, and then
Yes.
get your suture and put multiple sutures left and right so that it closes completely. Later we can do the iris also. If it is in a section also, we can deal with it later.
And very often we need something like a 8-0, 7-0, something. Because
6-0.
when it starts wanting to get out, there's almost nothing you can do. You put your, I sometimes have just put needles till I could manage the situation and let the needles be. Then finally when I got the right suture, then I would go and suture it. Yeah.
And let me tell you one thing, don't hide anything from the patient. You should be absolutely clear about the situation, whatever happened, why you have not put the IOL.
Right.
Yes.
Okay, thank you very much. This is very informative for us. Thank you. I now invite Dr. Arup Chakravarti to give his talk on intraoperative hard eye and shallow AC of an acute onset.
Thank you, Dr. Suvira and Dr. Sudeep, for asking me to be present for this hall. Before I start on my topic, I would just like to tell you that incidence of supracardal hemorrhage is very, very low when you're doing a scleral tunnel or a clear corneal incision surgery. We are talking about situations where we make long extracapsular incisions with question of putting sutures.
Okay.
And the rest of the things I'll just come as and when the topic comes up. So I'm talking about situations not because of posterior vitreous pressure where the phaco handpiece presses on the globe or the fingers press on the globe, speculum is very widely open and things like that. It is basically eye was okay to start with, and during surgery it becomes suddenly very hard. And this happens not very infrequently. A different spectrum. Sometimes it is mild and you can continue with the surgery. In certain situations, it is very, very hard eye, and then we like to postpone the surgery. So let's see this case. This was a patient with what are the videos don't move. Is the video not moving?
What's happening with the PowerPoint keynote?
I've never had this situation. Right. So this was a lady in her 60s, angle closure glaucoma. Yeah. So lady in her 60s, angle closure glaucoma on prostaglandin analogs. Anterior chamber depth was less than more than 2 millimeter. Now, if you see when I make the paracentesis, on both the occasions, the Memvier blade it impinges on the anterior capsule. So I was very careful. So there was no trauma to the anterior capsule. It did not open up. And at this stage itself, the eye became extremely hard. I have done nothing. I have just made two small entries into the anterior chamber. And then I immediately realized that there is a situation that I have to deal with. I started IV mannitol intraoperatively. And I'm just adopting a go slow approach. waiting for the IV mannitol to take effect, hoping that the eye will become soft, and then by the time I start doing rexis, things will become better. It does not happen. So you see me stain the anterior capsular trypan blue dye, and then inject OVD. I always tend to use a soft shell technique. Now I don't think about a supracardal hemorrhage here, because if that is the diagnosis that is made, patient will usually complain a lot of pain. And then patient has a beautiful red reflex. So the red reflex goes. You can see a gradual darkening of the red reflex. So this is maybe some kind of supracoroidal effusion, or that has happened as soon as I opened the globe. Remember, this was a patient with angle closure glaucoma. So I'm continuing the rexis. I think I'm hoping the anterior chamber will become deeper and the eye will become softer. And most of the time it takes that particular course. So rexis is slightly smaller. At the same time, I would not like the rexis to become to run to the periphery. This was a patient with angle closure glaucoma. Now my dictum is, if the pressure is more than 24 to 25, and the anterior chamber depth is less than 2 millimeter, I would have given a preoperative IV mannitol. But this patient had a very well controlled pressure with prostaglandin analogs. Anterior chamber depth was more than 2 millimeters, so I did not give IV mannitol. This was after this case, in all patients with angle closure glaucoma, I use IV mannitol preoperatively in these patients. Eye is still hard. I cannot go inside and do phacoemulsification. So then I decided that I will do a small quantity of pars plana vitrectomy. So I used a 23 gauge self-sealing trocar cannula system. And as soon as I did a minimal vitrectomy, the eye became softer. You don't really have to, we can still visualize the cutter tip behind the lens. And as you see here, so just a small quantum of vitrectomy was performed. Eye became soft, and subsequently the cataract surgery became very simple. I gauged the pressure with my finger, and it was within manageable limits. In certain situations, this happened as soon as the intraoperative hard eye happened as soon as I entered the anterior chamber. In certain situations, when you wait for the intraocular lens, or when you're finishing off with the cortex aspiration, the eye starts becoming harder and harder. And you will find it extremely difficult to push in the lens, or you'll find it extremely difficult to complete the cortex irrigation aspiration. So in those situations, it is always a good idea to postpone the surgery. So if it is early in the day that I had this problem, then I'll take the patient out of the theater, IV mannitol, and call the patient back maybe as a last case, and most of the times the eye settles down. Again, this is a cortical cleaving hydrodissection happening, so rest of the surgery goes on very uneventfully. So what I was mentioning was, if you encounter this situation towards the end of the surgery, and most of the time it is like that in a non-angle closure glaucoma eyes. So if that is the situation, then you postpone the surgery by a few hours. There have been situations where I have taken up this patient for surgery on the next day. Again, give IV mannitol, and you find that eye is extremely soft, and you really wonder why you had so much of difficulties on the first occasion. So preoperative counseling itself, should take care of all the issues. And no patient, you should not be telling that patient doesn't understand, and it is a very quarrelsome patient. Everything has to be explained beforehand to the patient. This potential for this complication is again discussed with the patient. So patient is prepared that the intraocular lens implantation or cortex aspiration, etc., may be taken up on the second day. Now this particular case also I could have taken up on another day, prepare properly using IV mannitol, have the globe softened right from the beginning, and then going ahead with the surgery. So for some reason I decided that I'll finish off the surgery on the same sitting. So that is the reason I had to go through the pars plana. And what I did is definitely possible by anti-segment surgeon. What Shuvendra Boral showed was something which is predominantly in the domain of a posterior segment surgeon. I don't think we need to really think about how they do it, and whether we can replicate it in our hands. No, you require a lot of training, a lot of expertise to deal with that. If I suspect supracardal hemorrhage in a patient like that, I'll just do stromal hydration, maybe put 1 or 2 stitches and come out and refer the patient to a posterior segment surgeon. Incidentally, my wife is a posterior segment surgeon, and they will take up the patient again, for posterior segment surgery in 7 or 14 days time, by which time the blood would have become fluid, the clotted blood, and it becomes quite easy to deal with. So this patient went up pretty well, and if you see Post-operatively, there is absolutely no hassles. Now, this was another patient that had a different cause of intraoperative hard eye. A patient in his mid-60s, a lot of systemic illnesses. Patient was on renal dialysis, had PDR maculopathy, had undergone unlimited number of intravitreal injections in some other center in the city. So he had a grade 4 nuclear sclerosis. I mean, this is not hard for a surgeon like, sitting on the panel who has been doing for 20, 30 years. So let us see, everything goes on very smoothly. The rhexis is about 5 to 5.5 millimeters in size. I stain, all these kind of situations have to be stained with trypan blue dye. It makes your visibility visibility of the capsule, and it gives your rhexis consciousness. At this stage, you please watch without blinking your eyes. There is a pupillary snap. Rhexis is adequate, about 5.5 millimeters, and this is the stage where a pupillary snap happened. Somehow I missed it. All right, and then eye became hard. If you see the subincisional iris, it has a tendency to prolapse. So I just thought that maybe it is a capsular rhexis block, because the fluid wave which has gone behind the nucleus is pushing the nucleus anteriorly, blocking the at the rhexis margin or the equator. And if I just ballot the nucleus, just try to decompress the capsular bag, things will be fine. But then at one point I realized that such a thing is not happening, and I'm sure I'm dealing with a situation where there's a posterior capsule that has been opened up. So again, I was very hopeful and very optimistic. I started off the surgery, I made a deep groove, and then I thought I'll do a stop and chop technique. At this stage itself, I saw the nucleus was tilted. The same zone where the pupillary snap happened. And maybe just 1 minute, additional minute. So now I continued with phacoemulsification at a more anterior chamber plane. And then at this juncture, the inevitable happened, and it was just waiting to happen. And the whole nucleus went to the posterior segment. Now, there is no question of fishing for the dislocated nucleus in the posterior segment. We are all anti-segment surgeons. First, do no harm. That should be our motto. So I thought I'll just do anti-segment toilet, clean up the cortex, do a little bit of anterior vitrectomy, and take up the patient on the second sitting. So this is how I closed the surgery. You can see the one chunk of the nucleus in the anterior vitreous. Patient went back. We could not do the vitrectomy on the same day because patient was very restless. Dialysis, after dialysis in a few days time, patient came back. So this is being done by the posterior segment surgeon. So they removed the nucleus from vitrectomy was done using a fragmentome. The nucleus is removed. I had a very good rhexis, a large posterior capsular end, but very good rhexis. So I used a 3-piece hydrophobic acrylic lens, put it in the sulcus, and captured the optic into the capsular bag. So you don't have to really alter the intraocular lens power. So basically, friends, in summary, you must be aware of the situations which can predispose to intraoperative hard eye. Take adequate preventive measures. Rhexis should not be small in hard cataract situations. There are certain precautions to be followed when you do cortical cleaving hydrodissection, which I mentioned here. Quickly run through the differential diagnosis of intraoperative hard eye, because you should know which cases you should be able to manage and which patient goes to the domain of posterior segment surgeons. Postpone further surgery if supracardon hemorrhage is suspected. And in other options, in IV mannitol, which I used, which it didn't work. Temporize, which I have already mentioned, and call the patient back to complete the surgery in a second sitting. And limited pars vena vitrectomy, which I have done. This is a little controversial. And as for a beginner, I would not recommend that you do pars vena vitrectomy to manage such situations. Thank you very much for your kind attention.
Thank you, Dr. Ari. You have a slide somewhere that you highlight the 4 or 5 different causes of intraocular.
I have not loaded it here. Yeah. So I can tell you actually what.
No.
Huh?
Show us that slide. You have it. It will be useful to these kids.
Just 1 second. No. Well, I'll just have a look. 1 sec. No, just 1 sec. Huh?
Till then, yes.
Yeah.
The standard gauge for the anterior vitrectomy
Yeah.
is around 20 gauge.
Yeah.
Disposable.
Yeah.
So, I think
No, we use 23 gauge. We routinely use 23 gauge. No, minute is taking time, so I think you better start off. Maybe if time permits, we'll show it. Yeah, because it is. I tried to save it. Yeah.
But like for me, I have a disposable anterior vitrector.
Your anterior segment unit comes with a 23 gauge cutter. If they're not giving you a 23 gauge cutter, then you insist on a 23 gauge cutter. So there is 20 gauge. Even the fragmentomes are today coming in 23 gauge and 25 gauge from certain companies.
Now, is there any role for aspiration? I mean, in case you don't have the gauge of butter, witness aspiration.
That's a very good question. In fact,
मिरर नहीं है ये नहीं आ रहा है ना
इसको फुल स्क्रीन
फुल स्क्रीन का बट ये नहीं जाता ऐसा ही होगा
बैक वाले इधर आ गए सेकंड वाला नेक्स्ट
यहाँ कंट्रोल नहीं कर सकता नहीं कंट्रोल नहीं कर सकता ना यहाँ पे इसमें भी आना चाहिए ना इसमें भी
Deepak, what's your question? We got to start quick.
इसमें भी ये फुल
When
स्क्रीन
to
आना
give
चाहिए ना
mannitol, how much time prior to starting the surgery if it is pre-op? And do you recommend peribulbar block is better for a shallow chamber or topical? Because I felt in few cases giving peribulbar helped.
Not on, yeah. So thanks a lot for your questions. There are, I think there are two parts. See, if I'm giving preoperative IV mannitol, 20% IV mannitol, 200 milligrams, started 1.5 hours before the planned surgery, and make the patient visit the bathroom before the patient comes to the theatre. Otherwise, he may become very uncooperative. And the second part of the question was.
I always felt
Yeah.
peribulbar was
No,
better.
whether you do it under
Shallow.
topical or subtenons or peribulbar, it is the surgeon's choice. You know, I mean, one should not say that, no, I do 100% topical and all that, you know. The patient that I showed was a very cooperative lady, and it was well dilated, just grade 2 to 3 nuclear sclerosis. So this is routinely, we done a topical. I didn't anticipate this problem. It happened, because it was angle closure, there would have been some kind of effusion. So subsequently, I use IV mannitol for all angle closure glaucoma patients. I do still under topical if the patient is cooperative. If the patient is
Intraoperatively, when you give mannitol, how much time should you wait for the action to come?
no, usually 1.5 hours is enough. You know, if you
Intraoperative.
Yes, the time taken for
intraoperatively it takes a
mannitol
long
act
time.
is
It
going to
doesn't.
be
Yeah,
the same.
it has to be given in a rapid bolus. You know, so it takes 20-30 minutes minimum for the this thing to
15-30
come down.
minutes.
But then the eye becomes very soft.
Continue your questions later. Dr. Minu now, we invite you, Dr. Minuathan, to give your talk on heart-stopping moments during IOL implantation.
Before heart stops, hair will rise. So first is hair rising, then heart stopping. Okay. So can we have the slides down, please? Thank you, Dr. Sudeep and Dr. Suvira, for this opportunity. We'll go on to no financial interest at all in any of these lenses or whatever is being shown. So this is my trainee doing. You can see a posterior capsule rupture here, and an IOL vitrectomy is done. Cortex is nicely aspirated, and whenever you want to place a lens into the sulcus, what happens? It goes into the bag. And if you want to place it into the bag, it goes into the sulcus. So it goes in. I told her, stop, it is going, you take your skin, hold it, hold the forceps and hold. She suddenly started shaking and then asking for some other instrument. Again, visco, and suddenly gone, dim. That's it. So don't panic. But it's very easy to say don't panic, but then if you don't find the right instrument, use some instrument and hold on to the IOL before it drops. Okay. Okay, this is my case. IOL is going to go in, and everything is done fine. I am not bluffing, everything is run fine. No PC, nothing, no problem. Just aspirating the visco behind the lens. So just after that, when I look at the PC, 2 lines. So I thought I'll just leave. I'll zoom up and see. Okay, zoomed up. What did I do? Nothing. Just placed the lens and washed behind. But now, when I pull the iris and see, it is not a PC rent. It is just 2 cortical fibers which are sticking to it. So sometimes very, very easy to get fooled by this. And sometimes if it is so also, don't pull and manipulate the IOL too much. It will stay there if there's a tear after placing the lens. And if it is not too large involving the area of the haptic. So this is another patient referred to us. And very funnily, the haptic is lying in the AC. IOL is inside. And IOL is in the bag and is very well centered. And haptic alone is floating and sitting on the cornea and causing corneal decomposition. So here, what should I do? I don't have to touch the IOL at all. IOL is very plastered inside, the optic is plastered inside the bag and well centered and all those. I don't know how it is so, but then still it is plastered. And the haptic is just retrieved off from the area of contact and then removed off. So these kind of bizarre things can also happen. People will leave one haptic free inside and send it to us, take it away. And all those, and patient will say, I cannot see now, after you have taken that something out, I cannot see. So that also is a problem, you know. So tell them that your lens is in bits and pieces, and so I am not responsible. So this one is my own one. See, look at the haptic. See, I cannot pause this here. That is the problem here. But the way the lens went inside, and this again, look at this one here, the haptic. The haptic should not be facing towards your right. It should be facing towards your left only. See here also, see, look at this. The injector part is overriding the optic, the tip of the plunger. That is what happens when this is what happens when that happens. When the tip is not bent and it becomes straight after multiple uses, it overrides over the IOL and there is a tight junction and you use more pressure and it flies in like a missile. And it went inside, nothing happened. I thought it was all okay. And then, okay, we'll aspirate everything. And pull and see, push, nothing is there, so I'm happy. But just see my arrogance, keeping on going there, keeping on aspirating there. What is there to aspirate so much there? Nothing is there, but still going on to that corner and keeping on aspirating. But then we realized that there was a little bit of vitreous there, and now if you see peripherally, there is a tear. Because of this missile going and hitting on the equator of the bag, the PC has torn there, and I pulled vitreous also there, aspirating it. So finally I do a little bit of vitrectomy. Haptic is well oriented away from the rent, and so you don't have to do anything on this, just leave it after doing a little bit of vitrectomy. Okay, another case. IOL is going in, not willing to come out. Haptic is not coming out. Trying to push, haptic is still stuck somewhere. And now I have to retract, but then IOL decides to go in. I come out. And so one haptic is not in, the other haptic is there. So it happens with all these butterfly cartridges where one of the tip of the haptics do not go in the right place and it gets caught between the. So I pull it out, keep it in the anterior chamber, put sodium hyaluronate into the bag, and then place another IOL into the bag after this. So I have always 2 IOLs of the same power of all cases, and then 3-piece IOLs of all powers. And this Apasami long straight Vanna scissors works for me for all cases. No financial interest in this, but without enlarging the 2.8 incision, I can cut any lens with this. Very sturdy instrument. But then if you have noticed, I hold the lens from the left hand on the optics so that it doesn't tilt. And after one half is taken out, see, the point is that if you place the IOL in, then you don't have a scare of touching the PC with the tip of your scissors. And also we should be careful not to cut on the rhexis margin or the iris margin. So once you go halfway through, you don't have to go full length. You can rotate it, bring it back, and then cut the uncut area close to you. You don't have to go very far. So here again, this is a femto case. So rhexis is fine. I'm just showing you. Just keep looking at the rhexis here. The capsule is intact, and the IOL goes in again. I'm a big shooter. Again, this shoots. And then it goes in, but it goes into the bag, and after that in this case what happens is the anterior capsule margin tears. See, look at the anterior capsule here. So I can preferably shoot on the posterior capsule, on the anterior capsule, anything I can do in the anterior chamber. Just to show you that in femtos there may be weak areas which may open up on pressure. It would not have happened if it was a regular manual rhexis. So this is again a single piece hydrophilic IOL, and here this is a little higher power IOL, close to 28-30. So these kind of lenses are bulkier, and once they go inside, see, these some of these cartridges are not well made, the tip of the cartridges, and injection was going on well, and suddenly you feel a giveaway like this. This is when the injector tip bursts open, splits open, and the tip is inside, and this is open here. See, the plunger has come out of this one, but the my haptic has been caught between the plunger tip and the cartridge. So here what we can do is to keep steady there and then split open the uncut area. Partially it is already split, so join that split to the tip of the curtain. Make sure you don't cut on the haptic. If you cut on the haptic and damage it, you'll have to explant the whole lens. But if you do not, then we can gradually open this cartridge up and then release your haptic and see whether it is damaged. If it's damaged or cut, or if it is too bad. If it is just a cut, that's okay. But if there is loss of material, then please always explant and place another lens. So this is a regular capsular rhexis. I'm just showing that the capsular rhexis is complete, and then phaco finished. So nothing big about phaco. So this single piece Technis lens goes into the bag. Remember, when you do not inflate the chamber or the bag very well, sometimes even very, very fine, soft looking lenses can rupture your posterior capsule. So injected a little bit more into the bag, and the bag was not fully open, and see was fully opened with visco, and see the line here. So I don't still believe that there is anything, there is just a line. So I aspirate whatever little cortex is still left there, but then I realize that it is a full tear which is extending from one limbus to the other, and it's inferior also. So in such cases I do not want to leave this single piece lens in the capsular bag, and I again go back, put in sodium hyaluronate, and in all these cases I do put in cohesive viscoelastic, no HPMC, no dispersive. Dispersive is very difficult to take out, but dispersive, if you feel that you want to plug the piece-around area, you can put dispersive there, viscoat I mean, no financial interest in that. Then after that, in the anterior chamber I would use only sodium hyaluronate, which will completely come out and will be fully taken out. So I could have left it there, but the haptic, see, it is into the area of that large rent there, and it is inferior. So this will definitely decenter and should not be left into the capsular bag, and that is dialed out into the anterior chamber. In the same way you saw the previous case happening, I place a 3-piece IOL into the sulcus when the IOL is still there and over the rhexis margin, and then cut this lens and explant. So this is the 3-piece lens getting loaded. The technique also, it needs a slightly larger incision, no struggle of wound assisted and all those stuff. Increase it to 2.8 or 3 or 3.2 if you want, and place it under the IOL. This is going under the IOL on top of the rhexis margin. So have a clear view of the rhexis margin. If it is constricting, use dilating drops intracameral, or dilate it with hooks and have visualization of the rhexis margin, and then only place the IOL in the sulcus. Once that is in, this IOL can be cut and taken out again. You want to see the cutting again? No, you have already seen the cutting. I'll just forward, because I can't forward it here because there is some problem in the alignment here. So the IOL is aligned in such a way that you can hold from the side port the margin of the lens. That is very important so that it doesn't tilt. Use this, cut across. If you partially cut also, you can rotate it and then take, there are different ways of cutting. You can cut a pie out, you can cut it into 3, you can partially cut and pull out. See, I don't want to strain the incision. Partially cutting and straining the incision and pulling out and all doesn't make sense. You make it into full, this is 6 millimeters, so you need more than 3 millimeters to take it out cleanly. Don't strain your incision. Make it at least 3 millimeters and take it out cleanly so that it closes well and it doesn't damage the edges and cause astigmatism. So my next talk for 3 minutes is wound burn. So nowadays it's not that very common that you get wound burns, because we're higher end machines and a lot of modifications have happened in the but many times when you have hard cataracts, this is 3 minutes, 2 minutes, fine. So once you finish, happily you're doing, and then you see this. Many times you don't realize because of the color of your sleeve and all this. So basically what is the problem? There are 3-4 problems. One is the size of your incision and the size of your sleeve. Machine company fellow people, they always have a tendency to tell you that this will go in through 1.8 sir, this is between 2.2 and 2.3 and also. See, whenever they say that it is slightly more than something, have it slightly more than what they say, because they will always want to say the smaller size and say that it goes through the smaller size. So if you have to squeeze your tip inside, then it means that it is tight for you. Make it slightly larger so that the fluid flow happens nicely through the sleeve on the incision. That is where it burns. And then the incision part, if you see this incision, it has to be adequately, see 2.8 is also fine. Sometimes the keratomes are not good enough. Some keratome they say it is 2.2, but when you put in a new sleeve also, it will be tight. So try to find out what your keratome is, and then stick on to your keratome and know your keratome. I always have one company's keratome, I just need to extend 0.1. Then only the 2.2 goes in very well. And here again, the next problem which happens is we look at the tip and forget to look at the incision. It's not possible to look at both with the microscope, And so we will be pushing towards the side, we'll be pushing towards up, tilting more. Tilting more means the upper part of the sleeve will hit against the incision and no fluid flow. And the heat gets transmitted directly. 2 other situations. One is the tip getting blocked with viscoat. See, put a lot of viscoat, you're happy, cornea will be, endothelium will be saved. And viscoat doesn't get aspirated that very easily into the one. So viscoat goes inside and it plugs. And then when you go in with phaco, no aspiration happens momentarily and no irrigation happens. And phaco power is on and you directly transmit the heat. Second thing is you have the tip or the tubing blocked with a nucleus piece, and you don't realize it, and you continue to do phaco, and then also you transmit it. Once you have this, and if it doesn't close by your hydration, please suture. 100% suture. A horizontal suture will be good to close it, close the lips together, and if it is good enough, fine. So one bite along the floor, come up on the roof, and then take another bite on the roof and come down in the incision and tie it in, and still make sure it doesn't leak on the table. You dry it and see. Spontaneously it should not leak, and also while pressing on the other side it should not leak. Press on the limbus and see. And the last one is making multiple radial sutures. One suture, it may be very small incision. 1, 2 or even 3 may be required to completely close it. So make sure that you completely close it, and sometimes it induces a lot of astigmatism, can't help it if it burns so badly. So try to keep looking at your incision also, whether some color change happens, and make sure that you don't press on your one. See, multiple sutures I am making, then it closes. So want of time, we'll stop. Thank you very much.
Thank you so much, Dr. Manu. Dr. Suvin is going to now either present or discuss with us all about IFIS. We've got about 14 minutes. Would you rather just discuss, or would you like to see his presentation?
He's finished by 55, so we got less than 10 minutes. We got just 8, 7. So.
Lights off, please.
So we're talking of intraoperative myocysts and iris prolapse. I'm sorry. So I do have a financial interest in the BX. I'll try to steer away from the BX as much as I can, but small people, you can't keep BX away. So this is a cataract, hard cataract I was operating, and did have the nucleus gone, and halfway through the pupil started coming down, a bit of intracameral adrenaline. Didn't really help much, some bit of dilatation, but then again, the nucleus was touching the pupil margin, so there was prostaglandin release and the pupil came down. So at this point, you need a device. So I did inject viscoelastic over the anterior capsular rim and decided to place a BX pupil expander. It works very easy over here because you can just tuck that flange. You can tuck that flange under the pupil margin, and then we have instant confirmation that the rexus margin has not been engaged in your notches, and you can advance it to the periphery, and you're sure. And once you've reached that pupil of 5.5, you're pretty good to go. So this is a video which has been going around from 2013, presented at ACS in 2013, and this is different grades of IFIS, some of which we didn't even know, and later on we kind of realized, and I dug them out from my archives. So this is a myopic, sorry for the video quality, this was taken from a VHS. So here the pupil keeps coming down on you, inflate the anterior chamber, the pupil gets, see that iris prolapsing over there, inject viscoelastic, and it kind of inflates again, and the pupil dilates. So that's very typically of an IFIS pupil, which will actually, it's elastic. Now some people have a feeling that probably iris hooks work better than other pupil expanders in IFIS. That's not really the truth. If you will see the next case over here, this is again iris prolapsing through all ports, and I needed to be a little careful over there while taking out the device, the IA cannula, but then went off pretty well. So this was harmless. Now look at the next case. I've used iris hooks. I could barely finish my capsular rexus, and my iris was totally frayed. So the device really doesn't matter. I'll come to that a little while later. So most important is when you have a situation like this, either you change your incision if you can, but if you can't, the best thing is this is going to engage your phaco tip. So best is to protect your phaco, iris with a side port instrument as every time you go in, and remember that your iris is also very patulous, so it's going to come and hit any instrument that you put in through the side port. In the interest of time, we'll just skip this. And so there is iris prolapsing. So what I wanted to show over here is it's not the device, it's the severity of the IFIS which matters. So we'll just move to the next. So this is a particular case where I was using, I mean, most of you would probably not use the device, even I wouldn't probably, but except for what I saw when I was just coming back with my visco cannula, and there was a little flutter over there when I just came back. So I didn't like it, and given the situation that we are in, short eye, shallow antechamber, I did think it would be a IFS case, and it did turn hypertensive. Hypertension is a risk factor for IFS, and so even with the BX you will have iris prolapse. So it's not the device which causes, which actually can protect you from IFS. There's no absolute safe way. So the problem is that if you have a pupil which has come down to half its size, your viewing area has come down to quarter actually. So, and that is a disaster. So if you would like to be safe, and we do try to predict the possible occurrence of IFS by we seeing the pupil size in advance. Well, it doesn't really work. 7 mm or smaller, irrespective of use of alpha blockers, can cause IFS. Some of us tend to believe it's a Western problem, not so. So this is a large study by Shilpa Goyal and co-workers, and it did say that the incidence of IFS was higher in India, and tamsulosin, alphazosin, hypertension was an important risk factor. That's a long list of situations and drugs which can cause. So it's absolutely unpredictable, and we need to be prepared. This is a list of complications. I'm sure we've all burnt our fingers. So a disciplined approach is required. Keep a stock of devices in your OR, and this rest is a routine, so let's skip that. What I would like you to probably remember at every point in time is that we've all burnt our fingers, and if it's your eye which is going under the knife, what would you like your surgeon to do? However skilled the surgeon is, would you like him to be safe or her to be safe and use a device, or take chances and use a skill alone? You could take a call on that. Fortunately, surgeons are reducing the threshold because of unpredictability of IFS and exacting patient expectations and the unforgiving nature of premium technology. We are using in more and more premium technology. Let's see this video by Deepak Magor. See the advantage. There are devices are good, but there are certain devices which will have advantages. The devices like Mulligan ring or the eye ring, especially in intraophthalmos, you really can't be sure whether you're engaging the capsular access margin or not, because from a top view you cannot see the sides where the pupil margin is getting engaged. So probably a device like BX, which is in a single plane and with the notches facing you, would serve your purpose better. Now, because the choice is yours, and it's not the hardness of the cat. So a choice of pupil expanders in intraophthalmos for me would be iris hooks or a BX, because they give you a lot of control and you are less likely to engage the capsular access margin. These are tight situations when you're there. So this is a question which often have been asked, is which would be the best device? Well, as far as I'm concerned, I would like to divide, as usual, IFS into meiosis and iris relapse. For the meiosis part, iris hooks or pupil expanders work very well, any of them, because it provides a constant pupil size and good visibility, which is, I think, it's paramount. So if you forget the iris prolapse and you just see that the visibility that you have, you need that central part to see that cataract and operate it. So both these, all devices will serve the purpose. You have safe phaco. For the iris prolapse, honestly, no device actually works. Nothing is foolproof. The iris prolapse depends on the severity of the IFS and the pathological damage to the stroma. So you may get away with one device and on one day, and the next day the same device will not work. It's just your luck that day and the severity of IFS in that eye. So I would probably prefer a device which has a low vertical profile and can exit through a small side port, and iris hooks and the BX serve this purpose very well. So this is very thin. It's about 75 microns, as thin as a human hair, and as you can see over here, you can remove it through a side port, which none of the pupil expanders you can do. So when you have iris prolapsing through all your ports, you'd probably prefer a device like this. So the lessons learned from these videos over here is that there are a host of systemic conditions which can cause IFS, and hypertension is an important risk factor. Remember that. Every alternate patient is a hypertensive patient. And IFS can occur in pre-op pupils of less than 7 mm or less, irrespective of alpha blocker. And tamsulosin is often prescribed to women. Remember that. UTI is common and they often prescribed. Iris hooks and pupil expander do not eliminate the risk of IFS. They may reduce the intensity of iris fluttering and prolapse, but they do maintain a constant pupil size, which allows you safe phaco. So every eye is an IFS candidate. Reduce your threshold for using a device and keep a stock in hand. I recommend you look up these articles that are there available online. Thank you very much for your attention.
Thank you very much, Dr. Sudeep. I think we are the session is almost over. Maybe we can take one question. If there's one question for Dr. Sudeep, to the next team gets over.